IBPJ Forum Series event will be focusing on integrating trauma and addiction, a paradigm shift using bottom-up, top-down, and systemic models. This event will be recorded for viewing, and I'm just really so glad that we have this opportunity. This recording will serve as an extended education and training video. It's rare that we can all come together and have an end-to-end conversation about treatment. And today, what makes it even a little more special is that it's somatic based. The speakers will cover cultural trends, scientific development, new clinical approaches, recent research, and treatment center experiences. So on the agenda, the panelists will each speak, and then we'll have a little pause for a moment in between so you can kind of stay with being in your body. And then after each panelist speaks for 10 minutes, we're going to go into a Q&A or a discussion between the panelists, and then follow up with Q&A from all of you. But first, let's get embodied. And here to do that is Serge Prengel. Serge is the editor of the Relational Implicit podcast. He's an alumni of 3 of our official USABP training institutes, Core Energetics, Somatic Experiencing, and the International Focusing Institute. His book is coming up to be reviewed in the journal, and he's the author of The Proactive 12 Steps, a mindful program for lasting change. And I will put that link in to the chat room. But for now, let's go to the program. Serge, welcome. Thank you.
Hi, guys. So we're going to be talking about all kinds of very stimulating ideas about trauma, about addiction. But for us, these are not just ideas. We're embodied people. And the intention we have at this gathering is to practice what we preach, to be present and process these ideas in an embodied way. And so throughout the proceedings, for instance, between each speaker, Liam will be inviting you to take a little pause. Now, of course, you know that a pause is not just a pause, like when you pause a video. Something happens when you pause. It's a disruption. It's an opportunity to get off the status quo and check inside what is happening. The pause is an opportunity to bring yourself in. And so we're going to start just right now. I'm inviting you. Close your eyes and check in inside. Where are you? What are you? I'm going to be checking with you what I'm noticing, and I'll leave some room for you to also check with your own experience. So I'm noticing that I'm swaying a bit. Maybe this swaying is kind of a reminder that I have a body, I am a body, I'm not just words. As I do this, I feel like my shoulder is needing to move, and I'm noticing how my breathing is shallow and my upper back is kind of tense. And as I stay with that, I'm noticing almost of its own, my upper back elongating, my shoulders opening a bit, and my breathing being less shallow, and I feel more present. And I'm inviting you to take a moment to check inside what you're noticing. I'm inviting you to sense into what gives you the sense that you're not alone and you're part of our larger community. And maybe it's just my voice that reminds you. But what's the sense inside of being yourself and being part of that community? And hanging on to that curiosity about what gives you the sense of being yourself and that back and forth. The forum is not just people who are going to be spouting some ideas at you, but is the integration that you make, that we all make moment by moment. And that integration is embodied. I know what happens to me when I stay in front of a screen for a while and I check in, I notice that I kind of get a little slumped. And what I've noticed is that it's not really that good to just tell myself, okay, come back, but to honor the slumping as a sign that there is something in me that maybe wants to pull back. And when I stay with that, I'm noticing my belly tightening and it's as if it's being pulled from there. And then if I stay with it organically, it kind of comes back. And I don't know in what way you do it, and I'm inviting you to have some curiosity. But I suggest that we might all have some kind of that movement of pulling back and coming back in. And I'm inviting you to follow that movement, maybe to do it on your own, to see in what way you might pull back and come back in. And that is just as organic as breathing. In, out, going away, coming back. And to observe how you're going to be processing organically, being part of a group and being yourself. Taking in, but also coming up with your own ideas. That in and that out. And it feels wonderful to think that all of us in our own way are going to be doing some of that. And we are part of this larger organism, living organism, where we're going to be taking in this information and making something of it, and then coming out and bringing it into the world. So just throughout this, I'm inviting you to remember to take a pause and bring yourself back and bring some of yourself into this process. And now, back to you, Liam.
Thank you, Serge. I appreciate that and helping us all to come in and feel connected together. And now moving into the panel presentations. Our first speaker today is Gabor Mate, a retired physician who, after 20 years of family practice and palliative care experience, worked for over a decade in Vancouver's downtown east side with patients challenged by drug addiction and mental illness. The best-selling author of 4 books published in 27 languages, Gabor is an internationally renowned speaker, highly sought after for his expertise on addiction, trauma, childhood development, and the relationship of stress and illness. His book on addiction received the Hubert Evans Prize for Literary Nonfiction. and for his groundbreaking medical work and writing, he has been awarded the Order of Canada, his country's highest civilian distinction, and the Civic Merit Award from his hometown, Vancouver. Gabor's next book, The Myth of Normal, Trauma, Illness, and Healing in a Toxic Culture, is due to be published autumn 2022. Today, he'll be addressing a clinical and historical perspective on treating addiction, trauma, and emotional loss together amidst a toxic culture. Please help me welcome Gabor Mate.
Well, thank you, Serge, for the introduction. It's a rather daunting task to spend 10 minutes on a subject I've spent decades on working and thinking about, but I'll do my very best and writing about as well. So let's begin with, so I worked in Vancouver's downtown east side, and Vancouver, British Columbia, the downtown east side sector of it is North America's most concentrated area of drug use. We have more people injecting, inhaling, ingesting substances of all kinds than anywhere in the Western world, really, in a few scroll-block radius. I was the physician at North America's first supervised injection site here in Vancouver. My patients were afflicted with mental illness, HIV, hepatitis, all the complications of addiction. 30% of them were Indigenous Canadians. Indigenous Canadians make up 5% of the population, 30% of our jail population, 5% of the general population, 30% of the population in the downtown east side, which already tells you that addiction isn't simply an accidental random event. It has to do with history, personal history, and the history of a culture. Now, why is it that Indigenous people in Canada suffer so much? Is because they happen to be the most traumatized segment of the Canadian population. For hundreds of years, they were subjugated, their culture was extirpated, their children were abducted from them, forced to be in residential schools under church guidance, where they were beaten, sexually abused, emotionally abused, starved. Thousands died. They're just discovering the bodies right now. In other words, there's a huge connection. And right now in those communities, there's high rates of suicide, high rates of addiction, high rates of mental illness, high rates of physical illness, and high rates of sexual abuse of children. And again, high rates of addiction. So that historical and personal trauma has everything to do with addiction. Number one. Number two, what is addiction? I'll define addiction for you as manifested in any behavior in which a person finds pleasure and relief and therefore craves, but suffers negative consequences as a result and is unable to give it up. So craving pleasure, relief in the short term, negative consequences in the long term, inability or refusal to give it up. That's what an addiction is. And I said nothing about substances because clearly people can be addicted to drugs, nicotine, caffeine, crystal meth, heroin, alcohol, but also, of course, to, thank you for the coffee, also, of course, to drugs, sex, pornography, work, power, profit, gambling, the internet, cell phones, and everything else you can think about. So the issue is not the external target of the behavior. The issue is the internal relationship to it. If there's craving, pleasure, relief in the short term, negative harm, inability to give it up, that's what an addiction is. And now I just simply ask all those of you who recognize that at some time or another, you had some kind of an addictive pattern in your life, to please just raise your hands. Okay, thank you. Hardly anybody leaves their hands down if they're honest with themselves. Now, the second question is, and this is where the whole cultural bias about what addiction is shown to be totally false. People make two assumptions about addictions. One is that it's, number one, a choice that people make, a failure of will, a character flaw, a deficiency of moral power, That's the one assumption. And in fact, that's the assumption that drives the legal system. The assumption is that people are consciously choosing to use certain substances illegally, and therefore they deserve to be punished. Complete and utter scientific nonsense. I won't spend a moment trying to refute it. I would if I had time. The second assumption is a little bit more interesting, a little bit more accurate, but still false, which is that addiction is a disease of the brain that somehow is generated by significantly by genetic factors. So let's look at what, that's what the medical belief is. It's got some elements of truth to it, but it's entirely inaccurate. Addiction is not a process that begins in the brain, and there are no addiction genes, never has been, nobody's ever found one, nobody will find any either, contrary to what you're told. So what is addiction then? So those of you that raise your hands, I'll ask you a question. Whatever your addiction process was focused on, behaviors, shopping, gambling, eating, drugs, whatever it was, the question is not what was wrong with it. You already know that. The question is what was right about it. So I'm going to ask you to put into the chat line what that addiction temporarily gave you that you were looking for. What did you like about it? So let's just see some of these answers. What did the addiction provide for you that you appreciated? Okay, numbness, relief, distraction, thank you, relief, escape, avoidance, sedation, thank you. That's good enough. When do people need to be numbed? When they're in pain. What do people need distraction from? Painful, internal body states, vagal states, and emotional states. What do people need to escape from? Distress. In other words, it gave you self-soothing, gave you pleasure. Now, in other words, the addiction wasn't your problem. Your addiction was your attempt to solve a problem. That problem was that of emotional pain. And hence my mantra, ask not why the addiction, ask why the pain. And if you look, and of course, that pain is not just mental, emotional, it's also an embodied pain. You can feel it, the tension in your neck, in your shoulders, in your belly, in your intestines, in your throat, and of course, in your mind. So not why the addiction, but why the pain. Now, if you understand why the pain, you can't look at people's genes or choices. You have to look at their lives. And this is where trauma comes in. I don't think I need to review for you the voluminous literature that has linked addictions to trauma, the adverse childhood experiences studies, so on and so forth. But we know without a shadow of a doubt that addiction is rooted in childhood trauma. I don't have time to go into it, but childhood trauma not only gives you emotional pain, necessarily, it also affects the body, as this group would know, and it also shapes and programs the circuits of the brain that then are become more prone to addiction, the natural opiate circuits, the dopamine circuits, the stress regulation circuits, the impulse regulation circuits. So having to bring this to a close, I'll just sum it up. Addiction then is an attempt to deal with a desperate and forlorn, but totally understandable attempt to deal with the impacts of trauma. And addictions are far more common in this toxic culture than most of us realize. Therefore, the treatment of addiction needs to be aimed at not simply stopping the behavior, which is only a symptom, but at dealing with the underlying embodied trauma. And for those of you that would like to read more about this, my book on addiction is called In the Realm of Hungry Ghosts, Close Encounters with Addiction. And the same subject is also taken up in the book to be published this fall, The Myth of Normal. With that, I will stop. Thank you.
Thank you, Gabor. Appreciate that, and we'll come back to you in a moment. But now, speaking on addiction from a polyvagal perspective, an unsuccessful attempt to feel safe in a body locked in a state of threat, is Dr. Stephen Porges. He's the distinguished university scientist founding director of the Traumatic Stress Research Consortium, Kinsey Institute, Indiana, university professor of psychiatry at the University of North Carolina, former president of the Society of Psychophysiological Research and the Federation of Associations in Behavioral and Brain Sciences. He's a former recipient of a National Institute of Mental Health Research Scientist Development Award. His author includes Polyvagal Safety, Attachment, Communication, and Self-Regulation. He's also the creator of a music-based intervention, the SSP, which is Safe and Sound Protocol. He's also the honorary director of research, USABP, and was the 2018 Pioneer Award recipient of the USABP. Please help me welcome Dr. Stephen Porges. Thank you, Steve.
Okay, I'm on. Let me just get my share screen.
Super.
Second. Okay. Okay. First of all, I want to thank you very much for inviting me, and it was really a pleasure to hear my good friend Gabor basically outline part of my talk, but I want to give a caveat to begin with. I am not a therapist, and just like the world of trauma welcomed me based on the theory, the world of addiction is now reaching out to me to try to, in a sense, give it a different understanding, because treatments for addiction have been more of a revolving door than a true sense of long-term recovery. So what I decided to do was basically use two slides, one to do a real quick polyvagal perspective, and we can go through this. It says humans are on this lifelong quest to feel safe. But what is feeling safe? Feeling safe is our autonomic nervous system talking to our conscious brain. It's our subjective feelings of our autonomic nervous system. So that's what really becomes critical. And what we start learning is through life, we want to feel safe, and we're going to do different things to change that physiological state. Why? Because that physiological state functions like an intervening variable. When it's calm, we have a great range of human behaviors. We can engage others, we can learn, we can perform well. But when our nervous system is in a state of threat, we then get reorganized and we're defensive, aggressive individuals. So the polyvagal theory actually names the circuits that form that evolutionary-based hierarchy to deal with safety, danger, and life threat. And that's hierarchical. When we're safe, we're containing our body's reaction to danger and life threat. But when we're not safe, these systems become vulnerable and can react. Feeling safe reflects that autonomic state that supports sociality and homeostatic processes, which means our mental health and our physical health are linked together with the autonomic state that supports sociality. All living organisms respond to danger, but mammals are different than their asocial reptilian ancestors, in that mammals evolved with a neuroception of safety, meaning that they detect, look for, and respond to safety. And when they respond to safety, those defensive systems turn down and we feel, in a sense, accessible to others. Optimally, social interactions have served as the predominant mechanism to calm the autonomic nervous system. And that becomes the next big question, because what happens in the world of addiction? In addiction, the world of addiction, addictions displace social interactions to regulate autonomic state. Addictions disrupt autonomic functions. They disrupt homeostatic functions and potentially compromise mental and physical health. Addictions disrupt feelings of safety and negatively bias our reactions, our neuroception, so that we're really locked into detecting threat and not into detecting cues of safety and being accessible. Addictions frequently recruit an autonomic state that supports defensive threat reactions, such as abuse and aggression. And this is very consistent with Gabor's statements. Short-term apparent benefits include dampening underlying feelings of threat, including reduction of physical pain and mental distress, while long-term consequences include a dampened neuroregulation of those feedback loops that support our bodily organs. And what does that lead to? It leads to end organ damage. And of course, you see addiction as having many comorbidities that are linked to autonomic dysfunction. So basically, this is all I really wanted to share, because what we're really talking about is a physiological state that supports health, growth, restoration, sociality, or a physiological state that, in a sense, puts us in a state of defense. And addictions, which may have started off with this need to become numb, to dampen pain, actually end up reorganizing and repurposing our autonomic nervous system from a social organism to basically a defensive one. So that's my brief 8 minutes, I guess I did in, or something like that. But we can move on. Thank you, Liam.
Thank you, Stephen. Excellent. We'll come back to that wonderful setup you just left us with. Now we want to turn to the topics of treatment. And here today, Jan Winhall will speak about the felt sense polyvagal model of trauma and addiction, seeing addictions as adaptive responses to maladaptive environments. Jan Winhall is the co-director of Borden Street Clinic, the director of Focusing on Borden, and a coordinator with the International Focusing Institute, another official training institute of the USABP. She's an adjunct lecturer at the University of Toronto and author of Treating Trauma and Addiction with the Felt Sense Polyvagal Model. I'm putting a link in the chat room to her book and some of her worksheet downloads for you all to have. Please welcome Jan Winhall. Jan, so good to see you.
Thank you, Liam. It's wonderful to be here and to have an opportunity to share in different ways of understanding the mysteries of addiction. I began this work over 40 years ago, and I started off by leading a group for young women who were incest survivors. And while the traditional psychiatric model that we were all working within in a hospital setting was telling me that, this was a kind of pathology and understanding these women, mostly in terms of having borderline personality disorder, I didn't buy it because it didn't really speak to what I heard these young women sharing with me. And that was that they recognized that these behaviors that were self-harming, like cutting the body, drinking huge amounts of alcohol or doing a lot of drugs, engaging in really unsafe sexual behavior, somehow they knew intuitively that these behaviors brought a kind of jolt or shift in the body that brought relief, either because it numbed them and gave them a sense of quiet inside for a while, or it activated and stimulated them when they were feeling kind of deadened inside. And so when I started to search around for different models, I found the work of a lot of feminist therapists who were working in a much more embodied way with survivors of trauma. And so people like Sandra Butler, who wrote The Conspiracy of Silence, she was presenting addictions as adaptive behaviors that brought protection and help to people when they were overwhelmed and there was no escape. And then Judith Herman, her book came out, Trauma and Recovery, and we all read this voraciously and really helped us to understand what she described as these jolts in the body, which is what I was hearing from these young women. And the relief that they brought, and actually Judith Herman related this to the autonomic nervous system. So this was kind of an early introduction to Steve Porges' work around polyvagal theory, the ways in which people were connecting this. Feminist therapists, Laura Davis and Ellen Bass, who wrote The Courage to Heal and were very dismissed, but they made these connections with what we called back then flooding and numbing. And these were features of the autonomic nervous system. So I went on a journey to try to figure this out, and in a different kind of way that was depathologizing. And I'll share here now. some of what I learned. So I found the work of Eugene Gendlin, who created and named the term felt sense. So back then, Gendlin was had originally worked with Carl Rogers, and he was developing a whole way of understanding change in the body that came from being able to quietly go inside and connect with a deeper sense of knowing that the body really carries. And this deeper sense of knowing, he called the felt sense. And he established kind of 6 steps to help people to find this way of knowing inside. Because, you know, we live in such a culture that really disembodies us. It takes us away from connecting with the wisdom of the body. And so Gendlin's work really formed a big part of my the model that I eventually created, the felt sense polyvagal model that I've just put together in a book called Treating Trauma and Addiction with the felt sense polyvagal model. So I started to bring focusing into my work with clients to help them come into the body and to tap into this body wisdom. This is the model that I put together, the client version of the model. We call it 6 F's, just to make it easy to understand. Up here, you see that there's this flight fight place that people often recognize in terms of, this is the autonomic nervous system. This is the sympathetic branch. We broke it down into different branches to be able to make it easier to understand. So here's flight fight, that's sympathetic surge. And then over here is the folding and collapsing place in the nervous system. This is the dorsal branch of the vagus that Steve really helped us to articulate these unique features of the dorsal branch of dissociation. So this was the real numbing quality that I saw in these women. And then down here, I called this flock. This is part of the social engagement system that we really engage in and activate when we come together and we feel that sense of enough safety to be able to do that. Then these are the 3 blended states in the model. The blended states really integrate here in this kind of fun and fired up place, both the grounded ventral part of the vagus and then the sympathetic part. And here you see there's this blending, which creates a kind of fun or play place in the body of safety, but also with some sympathetic energy, or a kind of fired up place that we can get to when we're passionate about something. Then over on the left side is flow. This is the place in the nervous system, a blending of safety and immobilization from dorsal. So this is where our meditation, our focusing practices happen. This is lovemaking. It's where we really feel what Steve calls being safe in the arms of a loved one. And then up here, I began to really appreciate that addictions were a function of this kind of freeze or fixate state, we called it, which is a blending of sympathetic activation and dorsal shutdown. So when we put it all together, then addictions begin to act as kind of propellers, I call them, or state regulation strategies, as Steve calls them. And they propel us from this sympathetic place of adrenaline pumping and cortisol down into the fold place of dorsal, or vice versa. And so here we begin to really understand that these jolts in the body that we saw back then are indeed propellers that shift us. And then what I began to really appreciate was that these shifts in the autonomic state in the body were like the felt shift that Gendlin talks about when we're in an integrated state, that this shift comes and the body carries a new kind of knowing. Now, there are jolts and shifts that happen in addiction, but they don't carry that same kind of grounded knowing that comes when we're in an integrated place. So here's the clinician version of the model, much more use of the polyvagal language of the mobilized state of sympathetic, the immobilized state of dorsal. Here's addiction. And this, of course, is the trauma feedback loop at the top part of the model. And down in the bottom, when we have enough safety for those of us who manage to live in environments like that, and lots of people don't, then we have these blended states of fun and flow, or ventral dorsal blending and ventral sympathetic blending. And of course, the ventral part of that vagus nerve in the parasympathetic that really is the home of social engagement and interaction. So I use the model a lot with clients. Some people, download it and put it on their phone. Some people put it on the fridge, but it's a way of what we call orienting to the autonomic nervous system and understanding where you are in your body in terms of how safe you are able to feel, and then what happens for you in terms of your experiencing. When we work with these different states, we use body cards that help clients to be able to really document and activate the right hemisphere as well through visualization. This is an example of a fight-flight sympathetic body card. You can see how powerful it is. And when we make body cards for the more ventral state, we use those as resources to act as kind of what we call handles in focusing for finding our way back to that ventral place when we're really dysregulated. What I also did was to create an embodied assessment and treatment tool, because I couldn't find a way of assessing clients that really was very embodied. I wanted to move right away from the DSM pathologizing model. And so in the embodied assessment and treatment tool, which is downloadable, there's a process recording table, which we'll look at briefly, which helps you to actually document your clinical notes online in an Excel spreadsheet using the embodied language of being able to understand. It's a generic model, and so you can apply any modality that you're using to be able to work with it. It has 8 components and 8 focusing oriented strategies that we use. And again, you can integrate your own. And in the appendix, there's a download for each of the different tools. So it acts as a process recording, it acts as a treatment tool, and also you develop an assessment experientially over time. Here's an example of how we organize the embodied assessment and treatment tool. You can then click into Excel and fill it in for each client that you're working with. And we have a kind of cheat sheet that we use as well to be able to work with it. So we start with the client experience and then the therapist response. So an issue that comes up in the session, you would document what was your response to that? What was your own felt sense experience in the session? Because of course, our bodies co-regulate with our clients' bodies. Then what was the component that you used in the EAT? So for example, the model that I just showed you would be one of the components we would always use to orient to the nervous system. Then the focusing oriented strategies, and then additional modalities. What other ways do you have, say in somatic experiencing or internal family systems, different models, neuroaffective touch that you're using in your practice? And specifically in working with addiction, I like to use the 3-circle practice, which is one of the components of the embodied assessment and treatment tool. And this comes from Patrick Cairns' work. It's a very simple way of working with addictions. And I integrated the autonomic nervous system into it. So that inner circle, the place of fixate, where addictions occur, This is an example of somebody, one of their circles, where you would list the very behavioral ways in which things that you want to do to manage. So we use a harm reduction model. So for example, this person is working on food issues and deciding they're just going to have 2 desserts a week. It also goes together with a porn addiction and smoking marijuana. So then the middle circle are the triggers. These are the dysregulated states in the nervous system, the flight fight state, and then the shutting down dorsal state. And so what are the places, the experiences in your life that activate this dysregulation? One of the ones that we see so commonly in addiction is, of course, loneliness. Could be conflicts with your partner, COVID, whatever is happening in your, it can be very systemic issues like racism, things that make the world a very unsafe place. And then the outer circle, of course, is what, the kind of the life worth living. So what are the ventral practices and the flow practices and the fun practices that you can engage in that really help you to build a safe enough life? And so we encourage people to do these practices every day and to work with partners. We have focusing partnerships and accountability partners. So this is one example of one of the practices in the model that can be used specifically for addiction. And that's it for now. So I'm just going to stop screen share and come back to the group. And thanks so much for listening. Really appreciate it.
Thank you, Jan. And we'll circle back with this conversation in a short bit. But let's just take a pause. And really, this is a good moment to take a breath in and just see where your body is at. Comfort, discomfort, irritation with the technology, just see what's here. And then we'll just keep moving into the next moment, right? Which is staying embodied here and having a bi-directional experience. What's our body saying to our heads and what's our head saying down to our body, keeping language simple. And let's work into new perspectives on the therapeutic use of touch in clinical work. Right brain to right brain implicit processes for integrated attachment repair. And to speak about that is Dr. Aline LaPierre, our past vice president of the USABP board, editor-in-chief of the International Body Psychotherapy Journal, which you all have seen today and will be getting soon as members. And she is the founder of Neuroaffective Touch Institute, just coming off of a presentation or class in Australia online. She's the co-author of Healing Developmental Trauma, How Trauma Affects Self-Regulation, Self-Image, and the Capacity for a Relationship. So with that, I'm going to put her book up into the chat room. And thank you, Aline, for coming here today to share with us.
Thank you, Liam. I know I've been part of planning this event with you and really excited about the idea of doing some special sections in our journal. And this is really for the journal, the first time that we will be doing special sections. So it's really interesting. So I'm here to talk about touch, and touch is in all ways controversial in psychotherapy. But what I want to convey to you today is that truly integrating a top-down, bottom-up treatment plan does require that we start thinking about the place of touch within that. And by touch, I don't mean just massage. I mean a deep psychological felt sense experience that brings a sense of yielding into safety. So the use of touch is not new. There's dozens of techniques of touch, but what is new is the thought that we can integrate the therapeutic use of touch within a therapeutic session, which means that the psychotherapist is also able to touch clients. And of course, the way our conceptualizations of treatments are now, The scope of practice of psychotherapists excludes the body workers, and the scope of practice of body work really tells the body worker that they should not tread on psychological territory. So that there's this body-mind split that is continued in our treatment plans. So what I'd like to suggest is that this separation, this split, actually at this point in time is so rigid that it has the valence of a taboo, and that we need to really reassess whether this is an old way of thinking, and especially in the light of what neuroscience has brought forth in terms of understanding the body and in terms of understanding development. So I have a few slides. Let me bring up my slides. There. So what we know about touch is that, well, it's called the mother of the senses, which means that it is the first sense to begin to develop in the fetus. And it develops actually from week 6 of gestation, before there's hearing, before there's sight, before there's speech. The sense of touch is beginning to form, the receptors for touch are beginning to form at the skin. And so if we are thinking about truly entering the realm of healing developmental trauma, we have to think of how do we reach the body, and how far can we reach? How far initially can we reach into the implicit memories of the body? And so with touch, we can reach very easily into these implicit memories that are not there in words, but that are there in sensations, and that are actually much more easily accessible than we realize. And as an aside, I want you to notice that in this little fetus, this is fetus at 6 weeks old, actually, you notice that there's this little red bulge right here, and that is the heart beginning to develop. And in our sensory systems, we have that exteroceptive receptors at the skin, and then the interoceptive, which Cynthia is going to talk about, is really forming in our organs. So even here in the fetus, the touch and the interoceptive system are beginning to come online. The research, Tiffany Fields is a woman who's done a tremendous amount of research on the importance of early touch. She works at the Touch Research Institute of the Miami University. And what she has highlighted is that touch is at the foundation of our relational experience. Ideally, when a mother is available, an infant spends a lot of time being held in the mother's arms, in the father's arms, in the caregivers. We're always touching, holding children. And how that holding, and whether that holding was secure, whether the mother's nervous system was regulated or not, will have imprinted in that infant's sense of relationality. And if there's neglect, that neglect will be imprinted deep at the beginning of where our social contacts experience starts, which is in how we are held from the beginning. The other thing that's important, and I think that makes an argument for the essential inclusion of touch in our treatment plans, is that as the mother holds her baby, a mother's brain waves synchronize to the baby's heartbeat. And any break in the continuity of their relations, of the relational field of that synchronization, is experienced by the baby as a matter of life and death. And the way that shows up in our clients, in our adult clients, is that they will begin to talk when they feel safe enough about some form of falling into a bottomless void, some way of floating in space, some way, an image that that shows some deep disconnection, and that one of the best ways to start to bridge into that early implicit neglect and that early implicit trauma is through touch. So I just put a slide here. You know, we talk about right brain, left brain, and I found that this illustration is kind of fun to show how the right brain is the one that is intuitive, body sensing, alive, appreciating, and loving the physical world and the environment, and our left brain is the part that is explicit and cognitive, analytical. And so we're used to turning to left brain therapy, which is really the talking cure for explicit cognitive understanding of what is going on. And so there's been an attempt to understand what goes on in the right brain, I should say the right cortical hemisphere, so that we've tried to understand the right brain from the perspective of the left brain. And that the possibilities that touch brings into the treatment modalities is that we could go directly into the right brain languaging. Right brain languaging is sensation, is the capacity to receive, is the intention that is carried through the touch that speaks deeply all the way into the cell imprints. Because what we are trying to heal in developmental work, in early developmental work, is these basic messages about our identity and who we are. And the three most basic messages are: you exist, you are loved, and your needs are important. And those are the essential needs for secure attachment. And there's no better way to really reach into these early imprints where we've all received these initial messages, which is how we were held, how we were touched, and how the adults around us were really able to connect with us on a bodily level, out of which that right brain, that left brain develops. And it's important to know, and this is my last piece of information, is that the left brain does not really come online until a child is 3 years old. So that we have 2 to 3 years old, so that we have this whole early phase of life where the basic imprints of who we are going to become are sort of set in, that is done through the right brain, through that implicit touch, through that sense of non-verbal connection. So maybe I didn't check the time, Liam, but
Okay.
there are many ways, and hopefully in our panel I can talk a little more about how the therapeutic use of touch is different than massage, how it's different to have a person do psychotherapy on one side and then send them for a massage or some other form of body work separate from the psychotherapy, and how it's important to bring them together.
Wonderful. Thank you, Aline.
Yes.
And now let's pause, connect with our breath, go down into the center of our emotional body, chest, thoracic area, belly, what's here. Just be with it for a moment. And now coming back in, we're going to work with research. And presenting today is Dr. Cynthia Price. She's going to be talking about mindful interoceptive awareness training for those in recovery. She's the research professor of the University of Washington School of Nursing, director, Center for Mindful Body Awareness, which is another USABP official training institute. She's the principal investigator of multiple NIH-funded randomized controlled trials for mindful awareness and body-oriented therapy for people in community-based recovery for substance use disorder. She's the co-author of 2 scales to measure interoceptive awareness, the scale of body connection, and the multidimensional assessment of interoceptive awareness. And she's also, of course, the developer of MABT. And I will be putting some of her upcoming event links into the chat room. But please, for now, help me welcome Cynthia. Cynthia.
Hi, everybody. Can you see me?
So good to have you. And by the way, she's also doing an event with us in April. I'll put that link in so you'll have more time with her then.
Thank you very much, Liam. And it's a pleasure to be here today with all of you and on this panel. And let me get these slides up. Oops, I just have to get rid of this. So, as Liam was saying, I've been doing research for a while and train people in the process that I'm going to be talking about through the Center for Mindful Body Awareness, which is a nonprofit. The work that I do is something I've been doing for 40 years. I started as in private practice for 20 years and then moved into research the last 20 years. And I started as a massage therapist. So it's a lovely, what I love what Aline said, you know, we have this split between disciplines that in my work I've been trying to bring together. So I trained as a massage therapist and as a psychotherapist and have been working using touch and psychotherapy, both, as I said, in clinical practice and now in research. So it was really working with a lot of women in particular, but men and women who had a lot of trauma in private practice, who taught me a lot about how what they needed in their recovery in order to, a lot of them had been in psychotherapy for a long time, but were really still very, very disconnected from their bodies. So what it was that was helpful to them to help reduce that avoidance and dissociation from their bodies. And that work is what really led me to doing research, because I was so aware of how critical it was for their trauma recovery, this body awareness piece. So this particular approach that I developed was really developed for research once I kind of moved into research work. It's an 8-week protocol that teaches basic processes of bringing attention into the internal body, which is really what interoceptive awareness is. It includes touch, psychoeducation, and mindfulness. And I just want to take a minute to talk about the neurocognitive research that has really kind of helped us understand the importance of interoception for emotion regulation and relation in general. It is the processing of sensory information. That's what interoception is, most of which is unconscious. And the conscious parts are what we refer to in clinical care as interoceptive awareness. But imaging studies have really shown us how disrupted interoceptive processing can be in people who have mental health disorders. This list here are people who've been doing imaging studies for a while and continued into the present moment, where they're really showing that interoceptive processing is not happening for a lot of people who have substance use disorders, post-traumatic stress disorder, chronic pain, significant severe stress, compared to people who don't have those same challenges. But the question has been, can we change that? And that's really where my work is focused. I have used this intervention now in multiple NIH-funded clinical trials that have pretty much been mostly focused on people in treatment for substance use disorder. So the first 2 have been with women in intensive outpatient treatment. You can read the results of those. They're accessible on links through the Center for Mindful Body Awareness website. and they're accessible through PubMed, which is a place where you can get free access to research that's been funded by NIH. And I'm currently now involved in a study for men and women using MABT as part of their treatment. If they're on medication, so Suboxone or buprenorphine, it's also called, for opioid use disorder. So what I want to talk about is a little bit about this approach, because it really builds on what we've been hearing throughout this whole panel. The importance of being able to bring awareness inside, how that leads to greater emotional awareness, and how that emotional awareness really helps us regulate, manage our symptoms, be in relationship to our bodies in a new way. And that's what this approach is designed to teach. And so I can't go into a lot of detail about it, but simply to say that we use touch throughout. And the point of the touch is to really help people bring their attention to their bodies, to ground it there. If they start to mind wander and bring their attention away and think about the grocery list, it helps them bring their attention back. And we all do that. Our minds all leave and go other places, especially when we're touching in sometimes to information or experiences that are difficult. And so touch is a way to help know where to bring our attention back. But we start this process by first helping people develop their capacity to simply have language for what their sensations are. And we do that through a massage-like experience, actually, where we're pausing over and over on the external body and helping people to use their language to describe what they feel. And that is really important, because later on, we're asking them to describe what they feel in the context of a more mindfulness experience, when in the last 4 sessions of this approach, we're helping people maintain awareness in very specific areas of the body. And the therapist is actually cupping or holding the areas of the body that the participants or the clients being asked to bring their attention to. And that helps people learn to be in present moment awareness internally. So this whole process is about how to learn basic processes of bringing attention inside. And then with mindfulness, which is present moment awareness with non-judgment and self-compassion, to learn to maintain or sustain that awareness in specific regions of the body, which helps to develop this process of having, as Aline was mentioning, emotions come forward, memories come forward. That happens when you're in a safe situation where you can really pay attention to how you feel internally. And that leads to having more meaning. So when what we're looking for in this work is not only increasing awareness, but having that awareness mean something. What does it mean to you to have your ability to come down inside and pay attention to how you feel and what you notice? And when you do that and you can sustain it, what happens is people's experience internally shifts. And we've been hearing about that shift, what Jen was talking about, and what Aline was talking about. And that shift happens on multiple levels. It happens in how we feel physically, it happens in how we feel emotionally. And typically when people learn to sustain attention internally, it's a positive shift. Instead of that place feeling dark and held in and closed, and maybe a little of, there's avoidance there. If you can hold it and maintain present and moment awareness, that place tends to open up. It tends to get lighter. It tends to feel more safe. And then people begin to understand their relationship to that place, those emotions, in ways that they hadn't before. And that leads to insight and behavior change. So we see that, I'm just going to quickly go over a little bit about what we're actually seeing in research. This is from a large study that I've completed, and it's been published. But you can see the lifetime interpersonal trauma. This was a group of women. It's 100% and how it shows up in multiple ways, childhood and adult trauma. But I think what's really important to notice as well is that 50% of these women have had almost no mental health care whatsoever. So they're in substance use disorder treatment. They've got remarkable trauma histories and really have not had much care. So when we look at, well, what are they learning this interoceptive awareness skills, are they learning how to better self-regulate in this kind of approach? That's a really fundamental question. And we look at this is one of these scales, and the questions around self-regulating through interoceptive awareness in response to any kind of distress. And the items are, can you bring your awareness to your body and feel a sense of calm? I can use my breath to reduce tension. When I'm caught up in my thoughts, I can calm my mind. When I'm overwhelmed, I can calm a calm place inside. So this line that's going up compared to the other lines are the people who received MABT. They increased their capacity to do this pre to post intervention. And this was maintained. This difference between these groups was maintained a year later, or 9 months later, a year out from the beginning of the study. That's pretty impressive. But people with so much trauma can really learn these skills in a short period of time. And we also see that there's substance use. The blue line are the people who got mindful awareness and body-oriented therapy in addition to treatment as usual. They're the ones who at a year out had maintained their reductions in substance use compared to other people who were either treatment as usual only or a treatment as usual plus a women's health curriculum, which was designed to control for time and attention in this study. So when we ask people also qualitatively, what did you learn from this work? And these are the primary themes. I'm not going to spend too much time on them, but basically these same things we've been hearing about through other speakers here. There's increased awareness of the body, increased ability to link emotions to sensations, increased self-regulatory skills, and acceptance, which is very, very big. The ability to accept your body, to accept your emotions, to be able to tolerate them, which most people with significant substance use disorders and trauma have a lot of difficulty doing. And what I want to end with is that we're seeing these folks who get this type of treatment, we're seeing that at 6 and 12 months out in a study where they initially got an 8-week intervention, are reporting regular use of the skills that they learned over the past 2-3 months. And it's typically this emotional awareness and regulation that they describe as the primary reason that motivates them to continue paying attention in this way internally to how they feel. It's not hiding from yourself anymore. And this ability to really be connected on all these levels that this person mentions in this. You can read the quote. So I'm going to end there. I think we have a lot to talk about amongst us. Thank you very much.
Outstanding, Cynthia. Thank you so much for that. You left us with some real pearls to think about. So let's pause. How are you feeling down inside? What are you noticing as we move through these topics? And then let's come back in here and address on the systemic side, an important piece, creating a container is sometimes we refer to, but specifically here, trauma-informed treatment center care. Systematically incorporating bottom-up and top-down approaches in a treatment center and its practices. And here to speak about that is Dr. Joanne Barron. She's the co-founder of Trauma and Beyond. She's a certified EMDR practitioner. She is also a neuroaffective relation model provider and training assistant. She's on the master level, and NARM is one of our training institutes at the USABP. She is also psychobiological relational psychology as a part of her work, and psychodynamics. So please help me welcome Joanne Barron.
Hello, everybody. First of all, I want to thank you, Liam and USABP, for inviting me to be part of this very prestigious panel. I'm honored and nervous because most of these people I have studied and read and looked up to. And so, again, it's an honor. What I am going to be talking about is how to incorporate some of these ideas into the treatment center setting. And my experience with treatment centers I think goes a long way back. I started working in addiction treatment in 1973 and have worked in many different centers, and for, as Liam said, for the last 3.5 years have been co-founder of Trauma and Beyond, which is an outpatient center for the treatment of trauma. But in the 70s, we started to see addiction treatment centers pop up all over the place. The world of treatment, addiction treatment and mental health were very separate. There was no talking to each other. There was quite a bit of hostility and animosity between the two groups. And we didn't even start hearing really about dual diagnosis, addressing the mental health issues along with the addiction until the 80s. Dr. Joe Persh, who treated Betty Ford, used to joke that the mental health field thought that addiction was a Valium deficiency, if you get what he meant. But anyway, in the 90s, we started to hear more about trauma being an underlying factor in addiction. And at the addiction conferences, we started to hear people like Dan Siegel and Alan Shore and Bessel van der Kolk. And we started to think about how trauma was really underlying addiction. Now, post-COVID and during COVID, thankfully, trauma has become much more recognized, not only in addiction treatment, but in everyday life. So most treatment centers these days say that they treat trauma, have a trauma track, or do some kind of addiction treatment, but very few really use an integrative approach. And so that's kind of what I'm going to talk about, is how to have steps to do that. One of the first things I want to say that what's really important in treating addiction and trauma is that we need to use a phase-based approach. I like Judith Herman's phase-based approach from her book many years ago, but it's important to note that most treatment programs are very brief. Addiction treatment programs, 30 to 45 days at most, usually. So there's not really a lot of time to do much more than stabilization, symptom reduction, and helping the person to feel safe. We can do that by using lots of the methods we've heard today: polyvagal theory, learning to really notice sensations in the body, learning affect regulation techniques. Those are the kind of things we're going to focus on in the first 30 days. So we want to look at stopping the substance use disorder and those behaviors, and seeing those behaviors as an adaptation to pain, an adaptation to lack of safety. And it is important that if we are working in addiction centers, that we really look for the trauma. Many times clients come to us and they will not report a trauma history. They have no idea that what they have been through, even though any of us would see it as quite traumatic, they have no idea that this is trauma or that it has any effect on them. So education about trauma, I think, is a good first step. Then after the 30 to 40 days after we have stabilized and worked with symptom reduction and given some affect regulation skills and some distress tolerance skills, we need to think about the next step and what is a solid plan for the next step. So how does a treatment center stay in its own window of tolerance? So I think that's a really important concept, because just like when we are treating trauma, we want to make sure our clients are in the window of tolerance. So if they're too activated or too outside of that, they're not going to be able to really embody or integrate the treatment. The treatment center has to stay in its own window of tolerance. What can we really do? What are we expert at? What is our area of expertise? And we need to recognize what we can do in the amount of time that we're going to have the client. We've seen lots of clients coming to us that actually have unfortunately been re-traumatized in treatment centers because the treatment center was trying to do too much and really opening up the wounds. And then it's time for the client to leave. And so we don't want to re-traumatize clients by doing too much too soon. We need to start at the top, looking at all of our policies and procedures to support safety, consistency, and respect for not only our clients, but for the staff as well. And I think that's very, very important. We need the treatment center to be safe and open so that staff can speak to management about what's working, what's not working, where do we need training, where do we need new policies to support our training and our level of expertise. What are the expectations? What are the caseloads like? If we overload with really big caseloads, we're not going to have regulated therapists, and therefore they can't be effective co-regulators of clients. So we need consistency. We need to know what to expect, what we can do, what we can't do. Staff training in trauma-informed care and in integrated care with body awareness is so important, but it has to include all of the staff, not just the therapist. Very often in treatment centers, the people spending the most time with the clients are the staff with the least training, mental health technicians or techs. We want to train and have an understand, and the staff to have an understanding, the people that are answering the phones, the office staff, the therapists, the administrative staff, the owners. We all have to be on the same page with the same vision of what this embodied treatment looks like. And that includes having the same language. It's really important for staff to not use a pathologizing language about clients, and that we see their behaviors and their symptoms as an adaptation to the trauma, to the addiction, and that addiction and other acting out behaviors is an attempt to regulate their pain, an attempt to self-soothe, an attempt to numb. And so we want a language around that. We want to have safe languaging. And we want to do ongoing supervision, not just for therapists, but for all of the team, so that we can process what's going on a day-to-day or week-to-week basis, because sometimes working with these clients can be very, very difficult, as you all know. They can require a lot, and our team needs to always be conscious of their own sense of being balanced and grounded, so that we can have a dual awareness when we're working with our clients. Not only that we are feeling into our own bodies, but we can feel into the bodies of the clients if we're grounded. The environment should be safe and warm versus institutional. It should have things around that support body wellness, blankets and heated pillows and just nice things to feel and touch. The groups should be small. Typically in addiction centers, there's lots of groups, but often group sizes are very large, and it's really impossible to track what's going on in the bodies of all the clients in the group if the group size is too large. So smaller groups, 6 to 8 people max. And it is okay to have groups in trauma treatment programs, by the way. We got a lot of flack about that. But the truth is, the clients really like being in community and hearing that other people have shared this same kind of experience and felt sense that they have. So groups can be very healing, but they need to be very small, and we need to keep them regulated. We need to keep checking the emotional temperature of the group. And the facility, does it support the body? Do we do somatic work? Is there yoga, movement, dance? Are the therapy rooms set up for movement? Can we get up while we're in therapy? Can the client move their chair back or forward so that they feel safe in the room with us? Are the rooms comfortable? Is it a place that they can feel comfortable? All of these things are really very important. Those somatic therapies are always an important part of integrated treatment. Understanding that many of the clients are not connected to their body. They do not feel connected. And so some of our speakers have talked about the very basics of helping them understand what the sensations are and really giving them a language and focusing on let's feel what's going on in our bodies. Understanding dissociation is really important, that the therapy team knows how to track it and is aware of the many different levels of dissociation, including DID. Not everyone can work with DID. We need to know what we can and can't do and respect that. Respecting the individual needs of each client. Every client's different. Not everyone is going to respond to the same type of therapies, to the same type of body work, to the same type of anything. So we need to have the ability to individualize treatment and customize it within our framework. Using bottom-up and top-down approaches. There is a place for some of the top-down, some of the cognitive, when we're teaching affect regulation skills and just stress tolerance. We want to use things like DBT, but we always want to bring in the somatic as well and referencing the body and what we're experiencing inside. We also, to me, one of the most important things, and Aline talked about it, is working in a relational right brain manner. Being resonant with the client, being in synchrony with the client, being with instead of doing to is an important concept. Who we are with that client. Can we feel into them? Can we have resonance? At the same time, staying grounded and have that dual awareness. And can we go to those really difficult places, those scary, deep, hard places with our clients? We need to have the ability to do that and stay grounded. I think I'm taking way too long because there's so much. So Liam, just give me a signal when it's time. So we want to start.
1 more minute.
Okay, so the big deal is that we don't want to jump into the reprocessing too soon. That can happen in stage 2. And even then, we want to use titration. We want to do it in a very integrated way, working in the present, doing little bits and pieces of the trauma at a time, coming back to the present and paying attention to our own resonance, and always leaving time to go back to the positive shifts and the resourcing. And I think I have one more slide, that the last the last phase is really reintegration, but we want to embody all of the resources and the positive shifts and the client's new way of being into really all the phases. And what we know is that as this newness begins to emerge with our clients and their capacity for relationship and their capacity for feeling is enlarged, this can be very uncomfortable for clients. And we need to expect that and be able to support that while they are in this final phase and going forward. So I know I've tried to say a lot in a short amount of time, so I talked really fast. I hope you can understand, and I'll save the rest for questions and answers. Thank you.
Excellent. Thank you so much for that. We're going to just take another pause for a moment and then go right into the panel discussion. I want to open it up with the panel. We've heard really important aspects of integrating trauma and addiction. And so let's just breathe, feel in. And just moving in from this context of treatment care in institutional or systems, I wonder, Gabor, if you could comment a little bit more on that. And I want to encourage anybody, if you haven't seen The Wisdom of Trauma, it's an excellent documentary. Gabor, you had spoken towards the end about how, about social structures and how our society feeds this complex of addiction and trauma, and then how we come through and from trauma feed into our systems, if that makes sense. And I wonder if you could talk about any envisionment of how we can more mainstream trauma and care that is top down, bottom up, and systemic.
Oh, thank you. Let's begin with what Steve Porges said about safety. Any society that promotes a lack of safety will promote unhealthy development on the part of its individuals. This society, for all kinds of reasons and in all kinds of ways, deeply undermines the safety of human beings from in utero onwards. We know already that even impact on the pregnant woman during pregnancy will have an impact on the stress regulation apparatus and autonomic nervous system development of the infant. So the inculcating of traumatic imprints begins in utero, continues with the very traumatic medicalized birth experiences of many women, and then through a childhood with the deprivation of the proper social and communal template for parenting, which our species requires and in which we evolved as a species for millions of years, then further entrenches a sense of lack of safety in people. Now, not to mention then specific big T traumatic experiences like abuse, neglect, and so on, racism, economic inequality. We know, for example, that racism, both racism and economic stresses interfere with the biological development of human beings on a very cellular level. I will not go into the details of that. I'm just stating a fact. So the restoration of safety then is absolutely essential in trauma treatment. Now, I know that many facilities not talk about being trauma informed, and actually, I wonder what's the opposite, trauma uninformed? I mean, it seems like trauma informed is almost like a redundant thing to say, except that in our society, for all the new awareness for trauma, which is evinced in the success of publications like my own books, Stephen Porges' seminal work, Bessel van der Kolk's work, Peter Levine's somatic experiencing work. For all that, institutionally speaking, it's barely made a dent. In other words, most universities, most medical students, for example, never hear a single lecture on trauma. Never, ever in all the years of training, even though trauma underlines not only all addictions, but all mental illnesses and most chronic physical illnesses as well. So trauma, for all the public interest it has gathered, is very much missing from the treatment industry, if you like. And it's completely missing from education. It's completely missing from the social system, social policy, and from the legal system. So in this brief period of time, I can only say that the biggest steps forward we can take in redeeming this fractured, stressed society is to introduce deeper trauma awareness at all levels, including embodied trauma awareness, including the impact of trauma on the autonomic nervous system, on our viscera, on our brains, and on our minds. And that any treatment system that does not deeply deal with trauma is only playing on the surface. Things like cognitive behavioral therapy, dialectical behavior therapy, as far as I'm concerned, popular as there are utter nonsense for the most part, insofar as they don't necessarily go to the traumatic physiological embodied imprints, but they play on a level of ideas. The introduction of trauma in addiction treatment, therefore, is essential, and not the least for the reason that anybody who comes in for addiction treatment is deeply ashamed. They see themselves as deeply flawed individuals. Now, as soon as you open the question, not what's wrong with you, but what happened to you, you're actually absolving them of blame. When you show the connection between their life experiences early in life, throughout life, for example, the biology of Black middle-aged women is not the same as the biology of white middle-class women. They're chronologically several years older. Not chronologically, sorry, biologically several years older, even though chronologically they're the same age. So until we deal with these broad systemic issues of inequality, the very system that we live in promotes aggression, individuality, competition, fear. In this culture, we're actually swimming upstream, trying to deal with trauma. But we have to, in order to rehabilitate the social culture, to treat individuals, and to actually get at root causes. Again, those that are interested in my work on this can check out my books, including the new one coming up. My own therapeutic approach, which is called compassionate inquiry, does indeed embody body train or body directed modalities. But all of the modalities listed on his website, the somatic experiencing and the sensory motor, and Stephen Porges' polyvagal work, Deb Dana's interpretation of Steve's work, Jan Winhall's work on focusing. All of these are major steps forward in taking the theory of trauma into the body. And with that, I'll stop.
Well, if anybody from the panel wants to jump in on that, I really want to encourage that.
I would, Liam. So,
yeah.
So part of the problem is clearly language. We're using the wrong language in part to talk about threat, to talk about safety, to talk about trauma. We basically externalize everything from the body. So even though this is a body-oriented group online, we're still using a language that is a language that's very external to the body. And when I, in a sense, got pulled into the world of trauma, I was kind of shocked by the focus on events as being causal in trauma. Now, events contribute, but the body is what's reacting. And so you can literally have your own monitor of whether you have been traumatized or not by how your autonomic nervous system has responded. So you can basically monitor your own body to determine whether or not an event has been traumatizing to you. It's the physiological reaction to it. We end up in a world that we talk about good stress and bad stress. This is, again, another crazy use of terminology. If our autonomic nervous system doesn't recover from the jolt, that's not good stress. That's when we've been traumatized. So we have to think about physiology or trauma as disrupting bodily processes, homeostatic function. And you see this in the clinic, the individuals who have had severe trauma, their autonomic nervous systems with the consequential illnesses or end organ damage or problems are quite aware. The other part I want to really kind of emphasize is that we live in kind of a world where we think that treatments need to be cause and effect. We forget about the individual differences of the organism. And this is where I try to emphasize in polyvagal theory that the autonomic nervous system, the neuroregulation of the system, is functioning as an intervening variable. If the system is, quote, functioning with good feedback loops, good recovery cycles, then interventions will flow through that organism and work very, very well. But when the system is, in a sense, very destabilized and locked into states of chronic defense, and this can be seen as inflammation, it can be seen as hostility or anger, it could be seen as dysautonomia, it can be seen as fibromyalgia. It's basically a body that can't regulate itself, and it doesn't have access to intentionality. And this is what Gabor was mentioning about cognitive therapies. Intentionality works fine when our body's in a state of safety, but when our body's not in a state of safety, the battle has already been won. The body wins, and it will try to protect itself through aggressive defensive strategies. So my bottom word is that we can't talk about safety, which is a common theme here, until we get an understanding that safety is really a feeling that is being projected by our physiological state. It can be, in a sense, measured. And I guess the other final thing is I will tell you that our institute, Polyvagal Institute, is on a journey of trying to shift the clinical world, not clinical therapists, but clinics in terms of medicine and other organizations to be, quote, more acknowledging of physiological state of the body, more acknowledging of safety. And the points that were made are really quite consistent with what we're trying to do. And that is, it's even the receptionist has to be trained, has to be aware that cues of safety are in their presence, in their voice, their facial expressivity, and in a sense, their accessibility to the patient.
Yeah, wonderful. Anybody else want to?
Can I jump in there, Liam?
Yeah, please.
So, Steve and I have talked a lot about this, that it's so important as a trauma therapist that you ask about addiction in the body, because addictions stop that body process from moving into social engagement. And if you don't ask, and people are not going to tell you because they're so deeply shamed in our culture, then you're trying to, as therapists, we're trying to kind of bring people out, and their bodies, their autonomic nervous system is very efficiently really stopping that process because they don't feel safe. So we must engage and ask about, how are you managing? And, addictions are really great ways of being able to numb and shut things down. But here you are now, the body has to kind of update, right? And the head has to kind of talk to the body to say, it's actually safer now to shift out of these states of defense. And part of the person wants to do that. So we want to really harness that, to really engage the autonomic nervous system as a collaborator in that healing process. And then it's not so hard to treat addictions because you're not working up against something. It's not a struggle in the same way. It's a checking in with the body and seeing, would this be okay? It's a gentle process of respecting the body's stuckness, but for a good reason, because it wasn't safe back then.
Let me make a final comment, or at least add something to what you're saying. With both trauma and addiction, because they're really talking about the same population, is that cues of safety can become cues of threat through association. So there's a second level where you think that the answer is, I'll give the patient cues of safety, they'll become accessible, they'll become co-regulators, they won't use addictive substance, everything's going to be fine. But once their body senses accessibility, its vulnerability to that nervous system, and it will fight that accessibility. It's going, in a sense, until you are gentle. So your words, Jan, are perfect, that the therapist has to be respectful that cues of safety can be cues of trauma.
Yeah. Yeah.
I would like to add something here, which is that building on what Steve just said, that the most important work we ever do in working with an addicted clientele or with any clientele is not with them, but with ourselves. Because they read our physiological responses on an energetic level far more acutely than they may read our words. So we can be saying all the right things and employing all the right modalities, but if we ourselves haven't done ongoing work to clear, be aware of, and be self-regulated of our traumas and be self-regulated in our interactions, we're not going to create that sense of safety. And as Steve so eloquently has pointed out, safety is not just a question of the absence of a threat, it's actually the presence of connection. So who they're connecting with, that is how we're showing up. And I can be in the same body and be aware of the same set of knowledge on 2 different days, but neurologically be in totally different states on 2 separate days, or even in the morning and afternoon of the same day. And how I'm showing up is going to make all the difference to the success of that therapeutic interaction.
Yes.
Which I'd like to jump in here, which I think kind of comes back to Liam's initial question around, what can we do systemically, and what Joanne was talking about in terms of treatment. The research I've been doing has been only in community-based treatment. So we're talking about, you know, the thousands of people who really have almost no access to mental health care, right? They're poor. They're people who,
Yeah.
you know, Medicaid and Medicare is what they depend on for any of their healthcare services, and there just is not, the services are not there that are needed. And then you add to that what, you know, both his Gabor was just saying, and also what Joanne said earlier, that we have so many folks in these facilities who really are not trauma informed, and there's so many folks who go into helping in substance use disorder treatment who have their own substance use history, and they're well-meaning people, but maybe they haven't also learned how to be embodied, right? So you're getting it. There is so much work to do to support this that requires an enormous amount of infrastructure to both train people on all sorts of levels, but also have insurance coverage at the national level, the federal level, so that we can hire more people, train them, have integrative services, have people get the access to mental health care that they need, which often is very insufficient in substance use disorder treatment. So I think it's almost mind-boggling how much we know what needs to happen, but moving to that level is so much about policy, so much about people understanding these things from a leadership level, both in individual treatment centers like where Jan is, to the state level where the funding comes through from SAMHSA, to the federal level, to our insurance. And so it's a little frustrating for me, to do this kind of research, to see how much has to happen. And then you're kind of left, well, you know what, I'm not a policy person, but that's really where the work needs to occur, right? And so all of us can help, but I think in the big picture, that's what we really need.
I just want to second that. I agree with you so much that we really do need to hit this at the policy level, because there just is not access to care. Even people, Medi-Cal, Medicaid, forget it. There's just not good care. Even people with insurance, often insurance will dictate how long they can be treated, at what center they can be treated at. Usually treatment centers that are contracted with insurance companies have less staff, less well-trained staff, unfortunately, because of financial considerations. So it's really difficult, and we really do need to have treatment much more accessible. So thank you for saying that.
I'd like to bring up another point, and that is the whole medical profession is not attuned to being present or interacting with patients. It's about tests and assessments, which in themselves are evaluative and threatening to the patients. We've created within the Polyvagal Institute a group of physician educators. They're in medical schools to discuss how to bring these types of concepts into medical training. And their stories are horrible stories. But the main point is that medicine isn't being delivered in a way that recruits the nervous system of the patient. I had about 20 years ago, I interviewed for an administrative position at the NIH. And I met with the director, who was Zerhoni at that time. And I said to him, we know too much to allow medicine to be practiced the way it is now. He didn't have a clue of what I'm saying or was saying. And of course, I didn't get the job. The different pragmatic aspects about medicine. And about, I guess it's 30 or 40 years ago, physicians gave up the regulation or control of medical practice into basically companies, and companies are just standing over them with a stopwatch. So many physicians who want to practice medicine, interact, and love their clients and be helpful are not allowed to.
Right.
Yeah.
Well, I can only say, Steve, that I'm very glad you didn't get the job, because number one, you would have ended up in an insane asylum had you got the job. And number two, the world would have been bereft of all the brilliant research you've done since then. But in terms of policy issues, I hate to be a wet blanket here, but I spoke to a leading Harvard physician. He's actually the director of a hospital unit at Harvard. And he told me that until recently, To even bring up the question of mind-body medicine was to jeopardize your career at Harvard. And he says that's changing, but it's very, very changing very, very slowly. And the impediment there is not lack of research. I'm going to say something very radical here. If nobody did a stitch more research on anything, we already have enough information, scientifically documented, voluminously published information on the mind-body unity, on the physiology of stress, on the neurobiology of stress and trauma, the polyvagal work. The problem is not lack of research here. The problem is the lack of application for the research, what we call the research or the science policy gap. And the reason for that gap isn't lack of knowledge, it's the institutional. These institutions represent in microcosmic form the values and interests of a materialist culture that has to separate the mind from the body. And so that we're up against not just individuals who are incapable of getting it, although the people who are capable of getting it don't get the jobs, as Stephen just illustrated for us. The people who get the jobs are by definition are the ones who don't get it. That's why they get the jobs. So we're talking about a huge institutional and systemic problem here. I don't have any wise words as to how to reverse that, but we're talking about fierce advocacy here, not just the spreading of more information.
Talking about money, big business, capitalism.
I wouldn't even go there. I think it's easier for people to think cause and effect. And that's why they went to molecular as opposed to a system. To me, it's such a surprise that people who work with living organisms know nothing about feedback loops. And that defines what medicine is about. It's not about living systems. It's about fixing a car or fixing a person. It's a misunderstanding of what the system is that makes us alive, enables us to live.
I'm just going to say that there have been remarkable changes, and they are small, but there are people out there doing really good work in medicine and in nursing. People like Joanne who are really helping to bring integrative care into substance use disorder treatment, but it's slow. It's not only incredibly slow, but it also, I think we have to hold that there are some minuscule changes happening, people who do see this, who are doing really good work. And I think we have to hold both of those things because both are true.
Yeah, let me respond to that. I would agree, but when I get into these discussions with my physician friends and ask how can we change things, it always comes down to dollars because everything's being run by the resource or resource allocation. And I always bring up what happened to obstetrics when they started to have birthing rooms because people were no longer having their deliveries in hospitals. So they were going to lose that whole market unless they changed their behavior. It wasn't the science, it was the dollars that changed the behavior in obstetrics to have birthing rooms. And I think it's if we start creating patient-centered, where we become aware of the body and the physiology, and the outcomes become better, and they don't go into more expensive procedures because they're not searching for a disorder. They I don't mean this in any dismissive way, is that their nervous system's in a constant state of threat. So they have inflammation, autonomic dysfunction, mental health issues. They're just in a state of threat. If it's not a just, it is really damaging. But if that can be downregulated and they can become more accessible and more the feedback loops to their body working, then it's going to have cost effectiveness.
Yeah.
So I'm so glad I asked that question, and it was very a vigorous combo. And this is part of why we wanted to have this event, to have this kind of discussion, to talk about what I'm hearing is advocacy. So with that, maybe we could just switch a little bit into advocating for our clients. And Aline, could you maybe share and take us back to where you left us, which is how is the psychotherapeutic use of touch different from body work or massage?
Yes, goodness. As I'm listening to everyone, it's like my heart is just bursting, because it's true. There's
Oh no. Aileen, you're muted.
You're muted.
How did that happen? Okay. All right. So I'm coming at, as I hear all of you talk about the issues of policy, I certainly have felt the effect of that, in that that taboo against touch hits me every day, and people, you know, the first thing people say is, you touch clients, aren't you? Isn't that the slippery slope? And that term, slippery slope, has come at me hundreds of times, and my heart just cries, because it's coming from a place of not knowing what touch can offer. And where I am in this work is beginning to train therapists to do the work of full integration. And even that, and mostly the therapists that come for training, therapists and body workers, some do work in agencies and they go, what can we do? We can't touch. But a lot are coming from a private sector and experienced therapists who are saying, we know we need to learn the integration. Where can we go to learn it? And so as the training, as we train more therapists, then they find that very quickly their practices are full, because there is a demand from the public to have a fully integrated treatment for many people. But in terms of how much, can I show a slide? I just wanted to show a little, to come back to
Yes,
the
please
body,
show that slide. Absolutely.
to come back to the body. Because I love this. It's like, as this is a baby, just looking at the baby, because really we're talking about coming back to traumas that are at the source, and noticing. Did I put a Yes. Noticing how this father is holding the baby. Notice the holding of the head. You know, this little baby doesn't yet have a musculature, so it's completely dependent for its safety on how it is held, how the hand of the father is supporting the back. So a lot of what we do, this is just a little example, but knowing that the sympathetic nervous system runs through the spine, the holding is really primary to creating safety and regulation in the vagal system, at least at this developmental level. And so what we do in touch, in the touch training, is the first thing I do is talk about yielding as a condition for creating safety, that when the body has a safe, stable person to yield into, and yielding is not just letting go, yielding is trusting that the support that is there for us can be counted on and is solid and is attuned to needs. And so we start by supporting the back. And I don't know, Stephen, what you would say to that, but then as and what happens is really tremendous, that almost everyone that experiences that back support is absolutely stunned at how in their bodies they did not know what support felt like. So even as they were trying to regulate their vagal system, there was a missing piece of information there. And you can see that, you know, from the sympathetic nervous system, that nervous system branches out to the organs. And as that sort of starts to fill in from the back, then the vagal system begins to calm down, and and is more accessible to regulation. So, and yielding as we have it is, in terms of implicit developmental movement, it's the first movement. We learn to yield into being held, and as we yield, we learn to receive. And until we know how to yield, it's very difficult to be able to receive. So that's how I would answer.
Let me just make a quick comment. I would change the word from learn until we, in a sense, allow ourselves to yield.
Yes.
Because we don't make it too cognitive or intentional. And the other part of the picture, it's very clear that when you support the back, the skeletal muscles no longer need to be tense, which means your sympathetic nervous system can downregulate, and the metabolically cost of that is great. So, and I will also share with you, my wife is Sue Carter. Some of you may know Sue. We did a few workshops together, and once I said to her, we were both on stage together, and I said, lean back, just fall backwards. And she fell backwards. And my comment was, this is the basis of society, and that is to trust someone.
Yes.
I'd like to make two comments here. One is that, Aline, I'd like to tell you a psychiatric horror story in my own experience, which is that when I was a medical student, I was assigned to the psychiatric ward, and I was declared the primary therapist to an inpatient, which itself is ridiculous. What does a medical student know about therapy? But there I was, and I was with this client, hospitalized mental health patient, in a therapy room being watched across a one-way mirror by the psychiatrist and his residents. And the patient said something at one point, and I reflexively reached out my hand, touched his knee, and I said, why did you say that? Now, what do you think the feedback was?
All
No,
hell broke loose.
No, that wasn't the horror story.
Oh, for the
No, the horror story was they said, wow. The psychiatrist said, and the resident said, that was amazing. How did you know how to do that? Where did you learn that technique? In other words, responding like a human being to another human being was considered to be an unusual, unexpected, and brilliant technique. That's the first point I wanted to make. The second is there's a wonderful book by Anne Fadiman about the experience of Hmong. These are Southeast Asian people who moved to the United States, and their interaction with the medical system. It's called We All Fall Down. And these Hmong, H-M-O-N-G women, when they give birth, their husbands, they don't lie down on narrow pallets, put their feet in the air, like Western medicine tells women to do. They squat, they sit, and their husbands hold their back. And they're much more able to give birth in an uninterfered way than women who are not held. The husbands literally have their back, regulate their nervous systems. As a result, their viscera are in a different state when they deliver their babies.
Yes. Yes.
Absolutely.
Yeah, thank you for that, because, and I'm really happy to hear both of your responses, because this is something I've noticed over and over again in clients and in the touch work. And I just, from experience thought, wow, this supporting of the back in terms of creating the safe of what is needed for the system to feel safe enough to allow that letting go and that capacity to receive the nourishment and the presence of another. And then the whole vagal system starts to unwind.
And I think related to that is just being in presence as a therapist, right? I mean, we all some of us really learn that and some of us don't. And I think the kinds of trainings that that many of us are offering is really helping therapists to really know how to feel and be in presence so that they can offer that to the clients. Because if we're not, right, we're not going to be able to facilitate that in our clients. And I think that is so fundamental and so much a part of what touch can help with, right? We're bringing presence in as a therapist to our clients feel that. They feel the safety of that touch. They feel the presence of that touch. It helps them then facilitate their own capacity to be in presence. And that is remarkably simple and incredibly important for this work.
So maybe we could we've been talking about touch, but there's also the felt sense world. And Jan, maybe you could tell us a little how you bring in the felt sense into therapy.
Well, I think we all are doing it. I think if Gene was here, he would say, oh, we're all working with the felt sense. It's not about, he had this thing called the felt sense that he did and trained people to do and nobody else does it. It's a natural process in the body, an introceptive process that is in the body. And Cynthia was describing so well. The piece that I think often people miss articulating that's really important is the presence of meaning in the felt sense, right? That it's not just about sensation, it's about how your body carries this whole situation. And so he started off by studying, people who they came to therapy and they had problems. They had an issue that they wanted to deal with. And he noticed that people who did well in therapy were pausing, as Serge helped us to do at the beginning. And as they paused, and the pause was welcomed by the therapist because the therapist wasn't afraid to pause, the therapist was engaging with the pause and building what I call a relational felt sense. And then as that we stay with that person so closely and beautifully, the problem starts to open. And then Jean would say, the body knows the next step. It's not like we decide the problem up here. We can use up here because it's both top down, bottom up. But as we're down in the embodiment, in the soma, the body knows the right step to heal, just like the sunflower knows to find the light. And Steve is smiling because this is where, there's this connection when we share about the polyvagal, just bringing that in, that sense of like the nervous system and the safety and how bodies know the right next step, as Jenna would say, if you give them what they need. And so then there's this shift that opens, and he would remark, and I saw this a lot. We all see this probably, like, it's not that things are all better once the shift happens and the next step. And it's not like it all feels good, but it feels better in the body. There's an opening, an expansiveness, a release. And ironically, in a sense, when we're with things that are traumatic, right? When we're with things that are so hard to be with, but we're not alone. We're with that other. And so we focus often in partnerships, mostly in partnerships. And this is amazing because you can then teach this to your clients. And I do groups where people are focusing partners. So they're being with each other in that relational felt sense. And that energy comes into the group as well. And co-regulating with the other person down in the body and in the whole felt sense of this experience. And then up comes the handle, step 3. So the way of symbolizing that experience, a word, an image, a gesture in the body, something that helps you to really get the essence of what that is in there. And then as you keep staying with it in these beautiful ways that we have, it opens and releases. So the meaning changes. And that's an important part of the felt sense.
Yeah.
And you look for that, right? You look for those openings with your clients in their bodies. You see a little tear come. You know how it's fascinating how you'll see a tear come, but they'll say, oh no, I'm not crying. But the body's crying, right? So you can notice the tear or notice this constriction in the throat, but gently, of course, and obviously with a lot of kindness, because we don't want to shame people, right?
Jan, I have a simple question. Can you have a felt sense by yourself, or do you need a regulatory relationship? So can you experience felt sense, or is it a product of co-regulation?
Well, I think you can, but we carry co-regulation inside us too, right? But yes.
Yeah. So the carrying is the visualization and memories.
Yeah, and the carrying of all of us here. So I'm having this felt sense experience, but all of body environment is one, as Gemma would say. So we all are in this, even if we're alone in the woods, we're with the plants, we're with the trees, we're with life. So it's alone, but it's not alone.
And
Yeah.
we're in the research that I'm doing with this particular approach of mindful body awareness, which actually grew out of my training and focusing too, Jan, is we're teaching people to do this alone at home on a daily basis, right? That was
Yes.
all those skills people are learning to use. You can use your own hand to bring your own attention in, right? And so absolutely, Stephen, people can learn to do this on their own at home all the time and to help them regulate.
Well, when you're integrated, you're not focusing, you're just living, and it's there and you have access to it, right? Yeah.
I would say that it goes back to co-regulation if it happened very early in life. Like, I mean, and Stephen, I think it really has to do with your point about trauma, is that trauma is not the events, it's what happens inside of ourselves.
Yeah.
So in that sense, externally, the same thing can happen to two children, but they're not experiencing the same thing at all, depending to what degree, like with that father who was holding that infant in that photograph that we saw, that infant will be internalizing the co-regulation of the system of the father. When that child does an experience later on, they're experiencing it very differently than the child, because they've internalized their co-regulation. They'll be experiencing it very differently than another child who did not have that kind of holding. And so we actually carry that, as Jan says, we carry that co-regulation internal to ourselves, not just in the sense of conscious memory, but actually in the sense of body memory and neurological imprints.
Yes, that's why I put the memory part of the felt sense in there to ask questions into, because the memory's in the body.
But Gabor, there's a maturational developmental model you're actually stating, which I agree with, that we focus in our society on self-regulation, and I think that creates the vulnerability to addiction. In reality, we can self-regulate if we have a history of early co-regulation. Basically we carry that with us, and that enables us to be by ourselves if we have to.
Which, by the way, I never learned as an infant, because you should have seen me the other day at the airport when I had to have one more COVID test to enter Canada. And, I wasn't very well regulated at that moment. So, which speaks to my infancy, actually.
Well, I knew you guys' time would fly by, and what a delight. We have a little bit more time left, so I wanted to try to switch over to another piece from Joanne. How can treatment centers evaluate what needs to be done in order to become more integrative?
Yeah, that's a good question, Liam. I think I talked about a lot of the points, but I think one of the things that's really important is to do outcome studies. I think that specifically outcome studies around trauma symptoms and how those symptoms have been not alleviated, but lessened or are not front and center, but also for the treatment center to have a mission statement which really talks about the philosophy and really names the integration and how that integration is going to happen, so that all of the policies and procedures can support that. We like to follow our clients at, I think it's 30 days, 60 days, 90, up to a year. And we can see by setting specific goals that the client has for themselves, are the clients doing better? Are they better able to regulate than when they came in to the center? And we also ask upon exit, what groups were most helpful? Which therapists were most helpful? We ask for feedback, and we kind of keep an open door policy for all of our therapists, so that we listen to them, so they can tell us, no, we need to do this other kind of group, or we need to focus more on doing ABC, whatever it is. And we try it out and bring it in. So it's this openness and curiosity that we have to keep as a treatment center. I think that is really important, as well as all of the other parts of the policies and procedures.
Wonderful. Thank you. I think at this point, we want to just shift as we come towards the end here and bring back Serge. Serge, could you come back and take us
I am.
a little journey out?
Just adjusting my screen a little bit. So yeah, it's been a journey. It's been a journey. And I'm inviting, by the way, I'm not on the screen, so I just want to double check if the technical part wants to readjust that. Angie, or
Hi, I have you spotlighted right now.
okay, not on my screen, but that's okay. So I want to invite you to check what this experience has been for your body, for your whole self. What has it been like? What is it like right now? Maybe lots of thoughts are coming up, and we're not fighting the thoughts, but being a little bit more curious about what's happening in your body. I'm going to describe what's happening to me, and I feel some shaking, something that kind of originates in the belly. And if I follow it, if I let it unfold, I don't know what it is for you, but for me, connecting with how strong the experience of visceral fears we're talking about, not as concepts, but what it must be like. And so I just want to leave room for you to see what it is that comes up for you if you let something come up from what you've heard, what touched you. What is your experience right now, having gone through this journey? Comes up for me too is that experience of holding the infant, that experience of connection that feels so moving, contrasted with the experience of the bottomless pit of terror. How wonderful it must be like to receive that, but how wonderful it is to give it, to feel it. As I am in this place, I feel that opening and connection as an embodied experience. What is it that's coming up for you that you want to bring with you? And just adding a sense of gratitude for all the people who shared their wisdom and experience and who made this event happen. And to all of you who shared it. Thank you.
Thank you, Serge. Really appreciate you doing that. And I want to thank our panelists today for all their preparation and this vigorous, wonderful conversation. And to our guests who are non-members, I want to invite you to come back as a guest or become a member. Can you imagine doing 12 of these in the next year? Because when you're a member, we do at least one of these types of events a month. And I've done 57 of them, and I can tell you it's in my body, this somatic practice. And you learn from so many different institutions to help you find your way in and through and to experience in co-regulated ways. That's improvisational, which is sort of what Serge was demonstrating today. So with that, if you would like to become a member, I wanted to tell you that, I don't know if I'm still on.
You are, Liam.
Okay, then I'll keep going, even though I can't see you all. But I just wanted to invite you as non-members. We will take your registration fee and we will apply it to your membership. So come become a member. You can email me at liam.b@usabp.org. And if you want to get any of our back issue journals, you're welcome to buy those, and you can do that on our website. And with that, I'm just going to encourage you to go to our events section to see what's coming up next, and the more events will be added. And I think that's it from me. Angie, if you have anything you want to close out with. Oh, I'm back on. I can see you all. This is good. I think we're good. If anybody from the panel, you want to close with any comments, please do. We have a couple minutes.
I'm going to show a slide to invite people to join the Traumatic Stress Research Consortium, if you don't mind. So, okay.
Yeah, perfect.
Except I can't find it now. It's not sharing. I'm sorry. But anyway, it's called, just send the email to trauma@indiana.edu. And we have over 1,000 trauma therapists. We're getting information on what works, about what types of therapies they think work for what types of clients. And we're also creating a client survey to get information from them.
Excellent. And is that by chance on your PVI Institute website?
No, it's on my personal one. It's
Okay.
Porges, whatever. It's stephenporges.com.
Perfect. So go to stephenporges.com.
Actually, I'll make sure it's on the PVI one. I'll put it up, have it put up there. That's polyvagalinstitute.org.
I put that in the chat room for everybody.
Okay. Yeah,
And,
just keep this.
Yeah, perfect. And then I'm also going to be emailing you all a survey. We'd love to hear how this went for you. This is our first forum. This event, like I said, the next issue of the IPBJ, the International Body Psychotherapy Journal, will have continuated articles from some of the guests here today and others on this topic. So look forward to that. And I will email you when the video is ready for you all to see. So
Maybe one more thing, Liam, that
Yes.
on the Polyvagal Institute website, we have a group, for those of you that don't know, on trauma and addiction. We now have over 900 people in this group. So you can feel the energy and the excitement of people really wanting to address this work through a polyvagal, through the autonomic nervous system. So please do sign up. We do free Zoom meetings once a month where different people take turns to present. And last time we had an Ask Me Anything with Steve. So
Yeah.
Please do come and join us.
Excellent.
So-
And then lastly, Cynthia will be presenting in April here at the USABP. So you can get much more of what she's uncovered for treatment. And Aline.
Yes, well, while we're making announcements, anyone who's interested in becoming a pioneer in integrating touch and psychotherapy, the Neuroaffective Touch Institute, and that's our website. We're starting the 2022 Touch Integration Foundation training in just a few weeks.
Awesome. And Gabor, I already submitted the Amazon link for your books that are out. And I know you have another one coming up in October 2022. Is that something they can pre-order through Amazon?
They can. There's a site for it on Amazon, both in Canada, UK, and the US. It's called The Myth of Normal. My compassion and inquiry training comes in two forms. One is not for the faint-hearted. It's very immersive, interactive, demanding of time and emotional commitment. That's a year-long course for healthcare workers, therapists. There's also a short version, much less expensive. You can do it on your own time. And it's a compassion inquiry short course. Beyond that, I just want to thank you for hosting me, and along with these other wonderful panelists. And it is heartening to see, in the face of deep societal unawareness, it's heartening to see these buds and seeds of awareness growing, and plants growing that are getting more cohesive and more influential. So it's wonderful to be a part of that. Thank you.
Thank you.
We need to hold
Thank
on to
you.
that, to each other, right?
Yes.
Yeah.
And that's what we're here for at the USABP. So this is a good way to go out. Thank you, everybody. We look forward to
Thank
seeing
you.
you again, and have a good rest of the day wherever you are.
Thank you all
Thank
so
you.
much. Thank
Thank
you.
you.
Thank you.
Thank you. Thank you very much. Bye-bye.